Good evening, ladies and gentlemen. So it's a bit of unluck and unfortunate that one unable to make up the visa. So anyhow, if I meet you in person, I think that's really a wonderful opportunity to improve our collaboration. But as it is not to happen, so that's what we will make. We will meet you all in a virtual platform. So first of all, I would like to thank the IMHO to give me the great opportunity to give the keynote speak today. So let me get into the topic now. So we are talking something from a low middle income country and a collaboration with an high income country NGO. So it could be a very good experience and it could be a story. So let me get into the topic, the overview. Only 2 chapters. The chapter number 1 talk about the problems of universal health coverage, and number 2 is talk about a partnership. So there's a figure. You can see that in the figure, the world has been divided into arbitrary line called South and North Pole. So I think you all are from that North Pole and we all are from the South Pole. So then there is a disparity and there is a big difference in the resource allocations and the research among those 2 poles. The whole story or the whole presentation will talk about how we can navigate and how we can fill that gap. So if you take about the concept of universal health coverage, still that's a daydream. So there are a lot of struggles to achieve that. So why is that? There are 2 reasons mainly. The reason number 1, so the countries which has less health problems, they utilize more resources. The countries who have more health problems, they utilize less resources. That's called 90-10 gaps. It means that the countries in the southern part of the world, they have 90% of the health problems, but unfortunately they only get 10% of the resources. But in the other way, the countries in the North Pole, they have only 10% of the health problem as a whole, but they got 90% of the health allocation. So it means that malallocation of resources. That's the one part. Second, so if they got an opportunity, if we got a resource, the resource is not managed in a proper way in a country like us, the low middle income country. So these are the 2 reasons why still the universal health coverage is a daydream. So what is the way forward? How we can address these problems? So then there's a concept called think globally, act locally. So in that part, if you take about that concept, so it builds on few approaches. So approach number 1. So we have to develop a capacity developing template. Then we have to go for a 360 degree of collaboration. Third, we do a continuous learning programs. And fourth, the research has been in a smart way, it has been utilized. So we can see how that capacity strengthening template work. So there are 2 components in the capacity strengthening template. Component number 1, so the countries who receive the resources, they should make the receptor point, the countries, they make themselves in a way to get the funds in a proper way and manage the funds in a proper way. That is the first part. The second part, so the country should be ready to accept new projects. They're ready to do pilots. So these are the 2 things for capacity template development. And the other point, this point number 2 for capacity template development, that is, so the country should be ready to accept the pilot program. So this is one part. The second thing, the 360 degree of inclusion. What's that mean? It means that so all the projects, all the stakeholders should be included. It could be an expert, it could be a lay people, doesn't matter. Everyone should be included. That is called 360 degree of inclusion. And the other point in the 360 degree of inclusion, that is the North Pole and South Pole, they have to communicate with each other. They should get into a shared understanding. So continuous talking and get a common understanding, that's very important. So that is the second part, 360 degree of inclusion. And the third part, that's called reflective learning. So always, every time we get some experience when we are launching new project, it could be a research project or health service delivery, every time it's a learning experience. When we get that experience, it should be a learning point. It could be a reflective learning. And the other part, the final part, supply. So always, when we want to start a research project or health system development project, we always think about fund. But there are many other things we should be considered. The fund should be a seeding fund. So once we got a fund from an NGO or research grant, with the fund, the system should be developed. The other way, if in any circumstance, if the funding agency find difficult to continue the fund, or else the funding agency's rules and regulations said that the funding can be utilized only for 3 or 5 years, after that, what will happen? So then when we receive the fund, we should consider all the funds as seeding funds. Then when you get equipments, technologies. We should carefully think whether the technologies and equipments is feasible to our part of the country. It is manageable with the available human resources. That is second part when we are always consider what when we are receiving some supply. Third, we have to get multidisciplinary team approach. So the things is not the fund actually. So we have to get down the experts from the other countries and the people from southern part and northern part, they had to work as a team. And finally, the integration. So now it's very clear, even though we struggle to achieve universal health coverage, but that is possible through this, based on these four approach. Producing a capacity strengthening template, 360 degree of integration, reflective learning, and smart way of using the supplies. These are the four key elements that will help to overcome the problems of universal health coverage. So now we think the questions here is how an NGO in the northern part and a small country in the southern part can be an example for a universal health coverage. So how that is possible? So rest of the talk, we talk about that story. So if you take the collaboration between the International Medical Health Organization, IMHO, and the University of Jaffna, the collaboration, it's based on the four pillars which I have mentioned. Capacity strengthening template, 360 degree of inclusion, reflective learning, and the effective supply. So this based on that. And we have different type of health challenges, but just for the sake of explanation, I have divided the challenges into age-wise. I mean children, women, adults, and adolescents in that category. The health challenges are in four themes like nutrition, chronic illness, mental health problems, social problems. So these are our health challenges. These challenges, I think, everywhere in the developing world. So now we come to a bit focus. That's the northern province of Sri Lanka. So that is the third biggest province in Sri Lanka, but less population and contribute very less amount for the GDP. And as I'm a person working in that part of the world, that part of the country, I strongly believe still the consequence and damage of the war is still happening. That affect the people, psychosocial elements and various other parts. So now we get into the topic. So now we get into this, how this universal health coverage part is implemented here. So capacity strengthening template. So there are two components in a capacity strengthening template. One is community-oriented primary care, right? And the second one is Center for Digital Epidemiology. Those are the two pillars that help us to prepare the template. At the same time, we are practicing a novel approach. The approach includes opportunity strategy planning. So what is that? So usually in the strategy planning, so people, experts get together and they produce a strategy plan. Then they try to implement that. But always the success of that is big query. But here we adopt a novel approach that we use strategy planning in an opportunity base. So we will explain those things when we go to the next slides. At the same time, implementation and evaluation will go together. And we follow, there are a few theories, multidisciplinary team, participatory action research, and so integrations. So these are the key elements which help us to produce that template. So let me see how that community-oriented primary care and the Center for Digital Epidemiology develop. So in the community-oriented primary care, so the focal point, a family health center, which is in the divisional hospital, is a part of a Sri Lankan healthcare system in a grassroots level, a hospital with minimum facilities. So we develop our focal point, the capacity building template point for family health center in that particular hospital. Then, so that COPC model is helpful for delivering the services. The second part, that is code, that's called Center Digital Epidemiology. So that's developed in a part of a university. So that center is help us to manage our data, reflective learning, gives good feedback, and managing the funds. So those are the two elements. Center of Digital Epidemiology and the Family Health Center are the two pillars for this program. So those two pillars will nicely help to implement the project. So in that universal health coverage, the implementation strategy, there are four components. Component number one, that is capacity strengthening template. Component number two, the 360 degree inclusion. In the 360 degree inclusion, we implement another important strategy that's called community health workers. Community health workers is a recognized term by WHO. Here the lay people are being trained to support the healthcare system. So the family health center and court, they identify. So what they do, the both two pillars. So there are three processes in the developing of community health workers. So what is called nomination, selection, and the empowerment. So how the community health workers will be nominated? They nominated by the grassroots workers in the health system, like midwife. So almost all these community health workers, the member of Mothers Club. So the public health midwife or PHI or Grama Sevaka, they nominate few people's name and they will recommend us, they will be a potential community health workers. Then our university, the Code and Family Health Center, with the help of other experts in the region, they will select few nominated people. Later, the selected nominated people, so they will empower, they will train by the experts. So in that part, the empowerment, that is the very key important element here. The empowerment per se, there are three main components in the empowerment. So that is, so we motivate the people, we use different strategies to motivate these lay people to become a community health workers, and we train them through a training module. And the third very important one is the mentoring program. So through these three well-planned channeling system, so make the lay people as a community health workers. So now in the four principles of introducing or improving universal health coverage, so I have explained that capacity strengthening template through Code and Family Health Center. Second, I explained about 360-degree inclusion through community health workers. And the third one, very important one, is reflective learning. Here we use a recommended approach called participatory action research. It's a mixed research methodology. In this part, you can hardly differentiate the participants and researchers. Both participant researchers are working in a common platform, and the real-time data will be selected, will be gathered, will be absorbed, and the data will be analyzed. It will be reflected in a nice way. In an iterative process, the program will be improved. So we are using this unique approach. It's very interesting. So the researchers and participants, both of them are working in a common platform. That is a third very important element we are practicing here. So then the last one, the supply. So in the supply part, as I mentioned, we almost every time we consider each and every funding opportunity as a seeding funding. And always we have a extensive, continuous discussion with the IMHO to make the things happen in an effective way. So these are the two things that make you get the supply. And whenever we get equipment and technological support, we are very, very, very careful. Because country like Sri Lanka, with an economical crisis, technological solutions may be difficult in a rural place. So we are really careful when we are getting some technological support. So you can see the project Rural Health Development. So the project funded by that IMHO. And you can see the pictures. The IMHO President, Dr. Rajam, came to Sri Lanka and he was with our community health workers. The other picture is so about our Honorable Governor, Northern Province. She is with all our community health workers. And you all can see the bigger picture of our team. So the Rural Health Development Project has three objectives. The objective number one, identify your community health workers. Objective number two, train them, engagement. Objective number three, they empower and they support. So there are three steps. Identify the people, train the people, engage them, empower them. That's a simple process we are doing. So then this diagram shows the chronological way, so how that process, the program evolved gradually. So then there are a few outcomes that have been mentioned here. So this is the one of the program. So one of the experience we have with IMHO. The fund has been transferred through the proper channel to the code. Interestingly, University of Jaffna, the first time in the history, appoint the layperson as a community health workers. It has been appointed by the University Senate and Council. So they are drawing salary from University of Jaffna. That fund has been donated by IMHO. This is a well-structured program. These community health workers are working with the grassroots level healthcare providers, midwives, PHI, and they have been supervised in the field by medical officer of health and the district medical officers. The University of Jaffna continuously improving the community health workers' capacity. You see how nice teamwork is going on, and everyone's role are really clear. Every party get benefit, so that this method not only support to the system, but it support to the community health workers and the community members. So the other program is the community health workers facilitated reproductive health program. Dr. Raghuraman, the senior lecturer of St. Gynae, he is the lead of the project. I am looking after the implementation part. So Dr. Raghuraman and their team, they identify few lay people, train them and make them as community health workers, allow them to work with the public health midwives, and they identify the reproductive health problems, but mainly we concentrate on subfertility. Because the subfertility, the people may think is not a real problem, but according to the statistics, the prevalence of subfertility is around 20%. So Dr. Raghuraman want to start that program very early. So he identified with this help of community health workers. The subfertility couples have been identified early. Then they refer to the division hospitals. So here they refer to the family health center. The people whoever really need the help, they will refer to teaching hospital. Here Dr. Raghuraman implement the FIGO guidelines. And you can see in this slide, you can see the outcomes, how we are improve the system, improve the healthcare of the community. So the next project, that's under 5 children nutrition project, the name as Amada Surabi, is led by Chair Professor Geetanjali Satyadas. Madam is a professor in pediatrics. So under the guidance of her, she developed a menu, a cost-effective, community co-designed menu for under 5 children. So then the menu has been trained to few identified people. So then this is a real program in step. So those people called target group, and they will train another set of group. Ultimately, that group will train the community members. It's a real step-by process. So then the menu has been developed by the community co-design program by the experts and the lay people, and the developed menu will be trained to task people. Those people will visit to the field. So then the task group will go to the field and identify a few mothers club members, train them. Then the trained mothers club member will continuously support the mothers who have the children with under 5 years. So nowadays, because of this economical crisis, under 5 malnutrition become a great burden. So Madam identified that problem early, and she has started, developed a proposal, and now we ensure the feasibility of the program, and now we are piloting it. So IMHO is ready to fund to that. Here the interesting thing is, so the community health workers initially identified by Dr. Raghuram and identified by the rural health project, those community health workers will be involved in this pediatric project. It's called, we are using the fund in an effective way. All these, so then you can see some pictures about the program. So now the time, I think we are at the real time. So I mentioned about earlier, all the funds have been considered as seeding fund. So then if you seed something, there should be, you should harvesting. So what about the harvesting of the seeding fund? So we have mentioned 3 programs: community health workers facilitated reproductive health program, rural health program, and Amida Surabi programs. All 3 programs effectiveness can be assessed in an effective way. Then it can be applied, or it can go for a bigger grants, research grants. We can show that we have started few program with a limited finance facility. So that will help us to go for a grant. So that is the first harvesting of seeding fund. The second one, we can collaborate with other NGOs, right? So like another very prominent and supportive NGO called Manidaneyam. So Manidaneyam is really interested to support to go for a sustainable employment for these people. And another NGO that already started to support us, that called Truth to Power. That NGO is really interested to do continuous capacity buildings of women. And whatever the project we already identified, we would like to expand the project through with the various other NGOs. The main interesting topic I would like to emphasize here is the planetary health. Now that is a hot topic, everyone talk about that. the planetary health project work can be collaborate with the regional collaborating center Singapore. So now we start to discuss about, explore about the possibilities. And then there are a few other NGOs called SJC 87. They're really interested to support our home-based care, community-based screening, and again, Manitha Neyam is interested to support school health programs. But so the harvesting things which I have mentioned now, but in that harvesting, and we have to enjoy the result as well. So we have started the programs in a small way. We start to roll the ball. So evaluation. So if the programs have been evaluated, and if we show the success of the program in a correct methodological way, there's a good opportunity for research. And University of Birmingham is ready to support us in this context, and they will help us, they will improve our capacity to go for a bigger grant. Already with the support of University of Birmingham, we get 2 or 3 grants. So then this work, the community health workers facilitated work, will support us to go to the next level. So then there are some outcomes I have been tabled here, so that show you that how much our project is effective, how much is help to the public. So then, as I mentioned, the expanding program, now we have started community-based cancer screening program and NCD program. We have submitted a proposal to IMHO. Here again, this community-based program, the community health workers have been already funded by IMHO, will be utilized for this purpose as well. So as I mentioned earlier, it's a good integration. And we plan to start community-based geriatric care with the support of IMHO and the SJC 87. And the very important other topic, that's planetary health. So planetary health, basically it is a program which helps the environment and the human beings. Up to now, we human beings, we all very selfish, we look after our own health, so we damage the environment. Now the planetary health, they talk about the concept, it supports the environment as well as the human being. It try to create the balance. So now we start to develop a project of planetary health that will really helpful to the whole planet. It doesn't mean the north or south, but everyone will get benefit from this project. So there are few approach we have identified, and there are few activities we have already started. So that as mentioned in this slide, the approaches and the activities. So there are few photos, there are evidence to say that we have already started the activities. So why we can be able to start the activities in a small scale? Because the 4 principles. We are capacity strengthening template we are having a 360-degree inclusion, reflective learning, effective utilization of supplies. So that make us to see the feasibility of any project in our part of this world. So then this planetary health project, it support the planet as well as it give employment opportunity to the people. So finally the school health promotion project. So in that project, we will, the photo shows that the community health workers funded by IMHO, and there are a few other sociology, psychology graduate from the northern part of the Sri Lanka has been funded by Manitha Neyam through another funding opportunity. Both people get together and they are support the well-being of school children. So that is the program, that is the next step. We are planning to move forward, expansion of the project. So now the seeding fund given by the IMHO, the seeding fund given by the Manitha Neyam, they merge together and we are moving to another project. So up to now I am talking many projects, many activities, but this is not a solo game. So I have a very efficient, effective team. So the teams, people have been visualized here in the photo. So you can see the community health workers, professors, lecturers, consultants who are working with us in the picture. I think now there's a time for the ending the session. Thanks for patient listening. So, but I feel it's a bit boring without seeing your face giving presentations, just seeing a wall. That is not really interesting and it's not interactive. But we don't have any other opportunities or any other options, so that's what I do this method. So the ending session, what is the take-home message? The take-home message is the collaboration or partnership with IMHO and University of Jaffna is a good example for a pragmatic approach of universal health coverage by collaboration of South and North Pole. It's based on 4 key elements that's called capacity strengthening template, 360-degree inclusion, and reflective learning, and smart work of using the supplies. Moreover, I would like to thank the IMHO we consider it not as a funding agent. We consider them as our elder brothers and elder sisters. They always mentoring us, support us, empower us, and so they are part of our program. So I would like to thank on behalf of the Faculty of Medicine, University of Jaffna, for the wonderful support the IMHO made. So we hope and we sure the relationship will be continued throughout, and we will explore more effective projects, and that will help not only for Sri Lanka, but for the countries, the low middle income countries. Thank you.